anybody who may be joining us post-meeting on the YouTube. So my name is Valerie Welch. I am one of the founding members for the San Antonio Birth Network. And we have with us a few of our members who are midwives joining us this evening for a Q&A panel. Thank you so much to those of you who have sent in questions prior to the meeting. I'm very sure that, hello Tracy, it's nice to see you.
Hi.
Hi, so I'm sure that all of you are familiar with one another if you haven't already met. And I was just thanking all of the people who sent in questions prior to the meeting. And we will go ahead and get started. If we could just do like a round robin of introductions. Welcome, Jenna. Nice to see you. My name is Valerie. I'm going to we will do a quick introduction first. I will let you know I'm going to introduce myself first, and then I'm going to go over to Robin on deck, and then we'll move from there. Let's see, I've got somebody else joining in as well. So like I said, my name is Valerie, and I am one of the founding members for the San Antonio Birth Network, as well as a labor doula in the Cibolo area and a Lamaze certified childbirth educator, a mother of 4, and a advocate for people's choices in reproductive health. So one of the passions of mine is bringing education about choices and about reproductive services and rights to the people around me. And I just wanted to thank you all again so much for joining so that we can help spread the word about options for obstetric and well woman care. So with that, I'm going to hand it over to you, Robin, and then we'll move from there.
Hey, what would you like to know? Sorry, I didn't do my homework.
That's quite all right. If you could just do an introduction, and then Julie, you'll be on deck.
Okay.
From there. Just to, introduce yourself. What's your business? What's your passion?
All right. I'm Robin the Robinschlag. I'm the co-owner of Westover Hills Birth Center. I have been a midwife for many, many years, and we just got this birth center going a little over a year ago, and are pretty excited about it. Still in the building phases, so I mean, or at least how many clients that wise, not the building itself, thank God. So I have 6 grown children and 14 grandchildren so far, and 3 cats and a partridge in a pear tree. How about that?
That is fantastic. Thank you so much for joining us. How about you, Julie? And then we'll go to Jennifer on deck.
I'm Julie Hatfield. I've been a midwife for 6 years. I'm the other owner of the birth center, and I have 4 kids. My last birth was a home birth, and it made me want to be a midwife. So I changed careers and became a midwife after my last one.
That is fantastic. What's one of the passions you have about midwifery?
I love teaching the women and letting them learn about all their different options, and knowing that, you don't have to do it one way, and it shouldn't be something just because somebody tells you that that's the way it has to be. You have to deliver in a hospital, or you have to deliver on your back, or you have to do something, that you have options, and that you should be your own advocate for what you need and want in your birth.
That is so fantastic. I love what you said. You don't have to give birth on your back. And there's so many people that you meet in the checkout line just presume that this is the way they do it on TV. I guess, I don't know.
Yeah. Well, my doctor said a baby wouldn't fit out the right way, or whatever the case may be,
Exactly. I think education about physiologic birth and what we're designed to be able to do is so vitally important and so shockingly missing from the psyche of birth I think nationwide, but I think San Antonio also in general. All right, so over to Jennifer, and then we'll get to Tracy.
Hi, I'm Jennifer Kelleher. My practice is called Birth Experience Midwifery Care. I am a home birth midwife with a couple of office options in San Antonio and in the Barney area. And I have been involved with midwifery care since January 2001. And that was following giving birth to my own 5 babies at home. And what I love about it is I love customizing care for individual families. And I love the educational components, helping parents build a foundation as parents, and learning how to find resources and how to research and how to know that they always have options.
Thank you. How long again have you been in practice? You said 5 years?
2001 is when I started, and I've been licensed since 2004. 2004.
That is so cool. Thank you. Tracy, it's lovely to see you this evening.
Thank you. It's good to be here. I'm also a home birth midwife, like Jennifer. I do not have an office. I do all visits in the client's homes. And I like being able to provide that option because I was one of those moms that had a lot of little children, and it was difficult for me to get out with everybody and go to visits. And I can offer that option. I have a deliberately smaller client load than some midwives. I used to work at a busy birth center, and it took away too much time from my family. I have 9 children of my own and 7 grandchildren so far. I had 5 of my babies at home and 4 babies in the hospital. And I attended my first birth in 1991 and knew I was called to be a midwife, but it wasn't the right timing. And before I got licensed as a midwife, went back to school for midwifery and became licensed in 2016.
I'm so grateful that you are a part of the San Antonio landscape as far as options for birth go. So kudos to all of you. I've honestly considered for about a half a second becoming a midwife. And I've got just enough of that on-call life already that I'm just kind of, thank you for all of you. And I also would love to welcome Jenna. I hope I'm getting your last name correct. Is it Schmokel or Schmokel?
It's Schmekel.
Schmekel, welcome.
Yeah.
Would you like
Thank
to do
you.
a little introduction? How are you joining us this evening?
Sure. Yeah, I just happened to see your post in one of the pages. I don't even remember. But I am a local doula. I've been in just kind of starting out. So I've been doing this for about a year and just finishing my certification. So I'm located in Seguin and work primarily like in Braunfels and San Marcos. So yeah, I just wanted to hop on and hear more from the local midwives in the area and just kind of get to know people better.
That is so fantastic. So did you say that you're like a preceptor as a midwife, or?
Yeah, I am just certifying as a doula right now. So maybe someday in the future, but yeah, I have 4 babies as well, ages 2 to 10. So and yeah, so just starting with the support role.
Thank you so much. And I'm so glad to just welcome you to the birthing community.
Thank you.
I've been a labor doula for, gosh, my twins are 11. Ooh, so probably going on like 8 years now. Okay. I'm in love with people who are in love with birth work. Frankly, I think that's one of like the other halves of my passion. So if we can have tea over Zoom sometime, let's definitely do it. Also want to send a welcome to Carmen Calvo. If you'd like to introduce yourself very quickly, Carmen.
Hi, everyone. I'm sorry I can't show my face tonight. I am just kind of checking in. I'm traveling, so I'm not able to stay the whole time, but I just wanted to kind of check in and say hi. and listen as much as I can. I am co-founder with Valerie of the San Antonio Birth Network and also the owner of the Nurturing Route, which provides birth and postpartum support to moms throughout San Antonio. I'm just here to, I know I've met most of you, but just learn a little bit more about your practice and how I can help you kind of spread the word, or how we can help you kind of spread the word about what you do and how you serve parents in the area.
Thank you. Thank you so much, Carmen. We have one other joiner with us. All I can see is someone by the name of PC. No mic, no video at the moment, but welcome to whoever you are. And if you'd like to pass a note or check in, please feel free to let me know, and I'll definitely pass along any information or questions that you have. So thank you very much again for the introductions. I just wanted to, I guess, get us started. I think that we all know here, like, what a midwife actually specifically is. Would anybody like to field the question, the elevator talk, how are you different from obstetric care? Oh, there you are, Julie. All right. I heard you mouthing it.
Yes, we are hugely different because in an OB's office, you're in and out, you're a number. They have to have a high volume to support their practice, and we are very, very different. We don't have nearly the volume, even at the birth center, don't have nearly the volume that an OB's office has. We spend a lot of time, 45 minutes to an hour at each appointment. We're talking about all aspects of your life, not just, what happens between the boobs and the pubic area. It's like, it's not just a baby, it's not just a bump, it's not just a belly, it's the whole person. And so everything that affects your pregnancy and your birth and all of you, it's all-inclusive care. And we're also more in the act of preventing issues from happening. So if we see that your numbers aren't quite making you qualified as anemic, but you're kind of leaning that way, then we're going to do things to intervene and start, dietary counseling, and hey, here's some supplements that can help, and here's some foods that are rich in iron to help boost these numbers, so we don't develop a problem. We're more preventing it, not just fixing the problems. So
you would say it was a holistic or more holistic approach?
The whole person approach, not just it's not just a baby, it's not just the bump, it's the whole person. It's the mom, it's the baby, it's the mom's support that she has at home, it's the the issues she's having at work, and the stress from XYZ, and it's the whole package. Right.
I love that.
Yeah.
Thank you so much. Jennifer, if you could jump in, how do you work with obstetric professionals when, what circumstances bring you to do so? Or are you completely separate, or midwives completely separate when it comes to reproductive care?
So for the vast majority, I feel like most families never need anybody other than their midwifery care provider throughout the journey of their pregnancy. We do fertility counseling, we do lab work, we order ultrasounds, we kind of field what would be common childbirth ailments or complications in office. It's part of our training, it's part of our skill, it's part of what we do. In the event that we need another layer or another level of care, and then we have established resources and connections to different types of providers throughout the city, whether that's a need to meet with an OB about an illness that needs medication or prescription, whether it's the need for a chiropractor for a chiropractic adjustment, whether it's the need for MFM that needs to help us get through a period of pregnancy for something like hyperemesis. So it just kind of depends on what is skirting just outside of normal, healthy, low-risk pregnancy, and collaboratively working to involve as many or as few practitioners that we need along the way.
That is fantastic. Thank you so much for that very, very thorough answer. I love that, for most typical healthy women throughout the reproductive journey, a midwife is perfectly appropriate. And even afterwards, is that right, Tracy? Or
After
even
pregnancy,
before or after pregnancy? How do midwives serve women of reproductive age?
it depends on the kind of midwife that you have and what their scope of practice is. But I think as a general rule, many of us are involved in preconception care with clients. And for all of us, I know here, we have all helped families with multiple babies in the same family. So we end up being a provider that they see the most in maybe a 20-year span of their life. If they have multiple children, then they get to know us pretty well. I also want to differentiate that out-of-hospital birth is for low-risk clients. And that's what we midwives are specialists at, is low risk. So I think, as Jennifer was talking about, that that's part of our skill, is knowing if there is something that we come across that is out of our scope, is helping our clients navigate those waters to find the provider that they need to help them with that.
That is so important. And I also love what you had talked about. There are different types of midwives. Is that right? Could you just overview for us just a little bit about what that means? And if I were a person of reproductive age considering a midwife to care for me, what would I be needing to distinguish or to mentally note as I'm making my choices?
Sorry, I have a pop-up screen on my screen. Let me close this if I can. Let me see, can you see me around the screen?
I can.
Okay, my computer has been through a fire and it's like not very helpful. Okay, they're the two most common midwives, and the midwives that are the most well known in our area are certified nurse midwives and certified professional midwives. I think all of us here tonight are certified professional midwives. We do not have a nursing background, and that differentiates us from certified nurse midwives. All of us are autonomous providers and do not have to have be under with an OB over us or us under their umbrella. I think that's probably the main difference between certified professional midwives. I think all of us here are also we're licensed midwives by the state of Texas as well. So we sit for board exam that we take to be licensed, and then most of us go on to also be certified through the North American Registry of Midwives.
Thank you so much. I think that is a very important thing to consider. So when it comes to being a professional midwife, a certified professional midwife, are you able to prescribe?
Are you asking anyone, or are you asking me?
I guess, yeah, is that something that CPMs are able to do? I don't know, Robin, would you like to field that one?
It totally depends on if we have standing prescriptive orders from a physician. So and every midwife will be different as far as what type of standing order she has, or if she has that capability given by the physician to call in prescriptions type of thing.
Does that mean that a CPM would typically have not necessarily a partnership in business, but a working professional relationship with a person who could
with a
coordinate and prescribe as necessary for ailments of pregnancy specifically?
Yeah, that varies as well, because not all physicians who are willing to sign standing orders are willing to be the medical director per se for like our facility. So it may be a backup physician, a consulting physician, just someone like that.
So as an as needed basis, I presume, is that right?
Yeah, and it varies according to everyone's practice style.
Thank you. Thank you so much. So Jennifer, we've heard from some of the other midwives regarding other professionals that consult and coordinate for well woman care. Do you, or pregnancy care, do you know of, or off the top of your head, any other reproductive professionals that make fantastic birth team that you typically work with?
There's so many. There's so many valuable contributors that are in a position to create a well-rounded team for pregnancy, labor and delivery, and the postpartum period. And that spectrum ranges from body workers, massage, chiropractics, acupuncturists, counseling for pregnancy is sometimes really stressful. Pregnancy psychosis is a very real thing. Postpartum depression is a very real thing. Postpartum psychosis is a very real thing. So fortunately, we also have in our city great opportunities for people that specialize in overall women's health and well-being. We have pelvic floor specialists that we work with and that our clients work with during pregnancy, during postpartum period, or in between babies, or before babies, or after you're all done with babies. Like, fortunately, we are blessed in this city that we have quite an easily accessible spectrum of providers that help enhance all parts of the process.
That's important to know. It's quite an exhaustive list, actually, too. That's fantastic to hear that you work with them so regularly that you know all of these other different aspects that make a really great reproductive journey for I think most families. I wanted to turn it over to Jenna. Did we say Schmegel? I know that you and I had conversed a little bit earlier online today. You had some fantastic questions for the midwifery group. Would you like to throw one or two out there?
I mean, I guess one that kind of pops into my head right away is about like the end of pregnancy and what are, I guess sorry if y'all can hear my kids, they're a little noisy. What are y'all's standard of care for, like, if someone goes past date and it's, you know, getting up to 41, 42 weeks, like what are y'all's standard protocols for that?
Thank you. That is a really important question. I'm going to start going counterclockwise. If we want to hear from Tracy first, and then we'll get to Jennifer and then the ladies over at Westover Hills.
So midwives in the state of Texas do have some guidelines that we are supposed to abide by, that a pregnancy should fall between 37 weeks and 42 weeks of pregnancy. Our bodies know how to do this if we leave them alone. Most of the time, things work out on their own. I do like to tell my clients, I try not to give clients the idea that they have to do anything to have a baby, because I don't want to give them the idea that their body doesn't work. And so unless they're showing no signs of going into labor on their own, there's a lot of natural herbal remedies. We recommend chiropractic care, a lot of different modalities to help get a woman going in labor if we can before 42 weeks. Most of us usually suggest women do some additional testing when they go post dates, like have a biophysical profile to give us medical backup that shows that the placenta is still functioning effectively and the baby's doing well. There's some guidelines they go by and a scale that they give us that they grade you on with that. So I don't want to give all the answers. I'll let somebody else chime in as well.
There we go. I don't want to mute. That was an awesome beginning, though. Thank you, Tracy. Jennifer, why don't you pick up where she left off?
So I think it's important to recognize from the very beginning that the 37 to 42 guidelines of term pregnancy is a little bit of a moving target. It has a little bit to do with the first day of your last cycle. It has a little bit to do with conception. It has a little bit to do with your health history. And so we try really intentionally to narrow down that scope either at the first visit or the first couple of visits. And sometimes we have an array of a date spectrum of when that 40-week due date, estimated due date would land on. Sometimes we utilize a first trimester ultrasound. Sometimes we talk about days that, you know, you were tracking your fertility and what you know about your body. So we work really intentionally at the very beginning to try and be accurate. And what I have found after nearly 20 years of doing this is that if you really take the time to work through that at the very beginning, it's very rare that a woman remains pregnant beyond that 42-week mark. It just doesn't happen very often. It's part of the body's design. It's part of the fertility process. It's part of the natural spectrum and scope of how long it takes to grow a baby that's ready to be birthed. In addition to that, if we do start approaching that 42-week mark, then again, we talk about consulting, we talk about checking on baby, doing a biophysical profile, which is kind of an elaborate ultrasound to see how baby is really doing in its environment of the womb. And then based on some of that information, we talk about all the pros, all the cons, all the options, and then make a new plan. And sometimes that plan is to reassess in 3 days. Sometimes that plan is to take some of those uterine, all natural stimulants. Sometimes the plan is to have a bodywork therapy. Like it's just, it goes back to customizing and looking at the big picture.
That was such an important answer. And I love what you also said about we prepare for this throughout the course of the entire pregnancy in order to help make a baby that's ready to be born in due time. And so I think that's a really important distinction regarding the approaches of midwifery practices in general. So thank you for adding that to the answer. Ms. Robin, Ms. Julie, do you have anything to add on that question before we move to something medical?
They covered it pretty well. Yeah.
That is fantastic. So we have with us also, some of you may know Jennifer Hamilton. I just wanted to give a quick plug. She is also a birth photographer and a really cool person, and she's never ever sick at sea. In addition, she also had a question that she has either pondered or fielded from some of her associates. So I'm going to go ahead and turn it over to her as well. I don't know. There we go. Hi, Jennifer.
Hello.
Hamilton. So many Jennas.
Yeah.
What was your question?
Timeless. So I've had clients and other people that were just interested asking about why is a breech automatically a cesarean in the hospital, and if a midwife is a safe alternative, or if there's a reason that a baby should not be allowed to be born vaginally breech. I know a little bit about that answer. But I thought that would be a good thing for the midwives.
All righty, so we're gonna go keeping the circle going. So Tracy, you're up first.
Okay, I probably have the least breech experience out of my company here. I have attended some breech deliveries, but I've only been the primary midwife for one breech delivery, mostly because midwives are pretty good at getting babies to change their mind and turn the other direction. So we don't see a lot of breaches at term. But to a midwife, a breech is just a variation of normal, and midwives are taught to manage breaches. Whereas a lot of medical providers these days do not have any vaginal breech experience. And I can kind of go along with, I don't know if I would want a doctor trying for the first time to deliver my breech baby if they hadn't had any training in that area.
Good to hear. Jennifer, your thoughts?
Again, building off of what Tracy said, that it's a variation of normal. It doesn't make you or your baby abnormal. It doesn't indicate that there's reason to be fearful of a natural vaginal birth if your baby is in a breech position. of course, we go through all of the things to try and encourage your baby to turn. One of the things that midwives do that is different throughout care is that we put our hands on your growing fundus. We put our hands on the outside of your belly, and we connect with your baby. We feel for your baby's position. We palpate for your baby's position.
You don't just measure with a tape measure?
No, and we don't pull out that Doppler just to check on the head either. Okay. So we kind of have an assessment as pregnancy care progresses of what does this baby favor? What's this baby's favorite position? What does this baby seem to not? What position does this baby not seem to favor? And then we talk about, is there tightness in the pelvis or tightness on one side of your abdominal muscles? We talk about, have you ever had an injury that would indicate that your baby would only favor the right or only favor the left, or in some situations upside down, or in some situations back to back? So we are assessing and evaluating that all along the way. As you get closer and closer to that estimated period of term, we're encouraging you to have good posture, to use a birth ball. We're encouraging you to educate about optimal fetal positioning. We're talking about dangling your body or dangling your belly or slinging your belly in a downward position to help encourage baby to get into that more ideal position. Occasionally we have babies that the most ideal position for them is head up and bottom first. And if that's the case, and we've gone through the full spectrum of nudging and gentle suggesting to this baby, and this baby for whatever reason needs to be born not head first, then we discuss that. We discuss the options, we discuss the pros, and we discuss the cons, and we talk about what that looks like and how it looks different than a baby that wants to be born head first. And then we kind of move forward with whatever that plan is, whatever is best for that family.
That is really, really important. And I love what you also said, this is a discussion wherein the parents and the person who's giving birth is a part of the equation in determining what is best for each individual scenario, which I think is a perfect segue. Julie and I were speaking at the very beginning of the call regarding risk assessment and determining what constitutes a good enough or a bad enough reason to transfer to a obstetric professional for their expertise. Can you talk a little bit about that? Either Robin or Julie? Fight amongst yourselves.
One thing I'd like to say about, breech position, you read in textbooks that it's like absolutely once your water breaks or once you're in labor, there's no way for baby to change position. And that's not true. We've seen it in births where babies presenting breech, parents have been told the pros and the cons of having a vaginal breech birth, of the slightly higher risk to mom and baby, and they've chosen to attempt a vaginal breech birth just to find out that baby at the last minute, 6 centimeters, 8 centimeters, somehow, some way manages to have enough room, even with their water broken, to flip and come head down. And so that's not an impossibility. But we've also had moms who were told by a provider that their only option is a cesarean. And we do offer and to discuss with women who find themselves at term and have a breech baby. We will discuss options with them. We're not guaranteeing everyone the opportunity, but we do, it's a risk assessment for us and for the client, and we all have to be in agreement that this is something we want to move forward with. And we offer to a lot of clients to offer a vaginal breech birth if they're a good candidate.
I think it's important that you mentioned this is a conversation that starts as early as possible, as you know, any variation of normal, the risk assessment conversation, and
Yeah.
helping people who are giving birth understand that there are some circumstances that require transfer of care. Can you talk a little bit about that, please, Robin?
Some things that would risk a mother out would be preeclampsia or gestational hypertension that can't be controlled, gestational diabetes that can't be controlled with just diet and exercise. More than twins, if someone is coming in with higher order multiples, that would definitely risk them out of hospital birth care. Let's see, what are some other things? Autoimmune diseases such as lupus is contraindicated for out of hospital birth. Gosh, you know, and often it's not just one thing. It can be a kind of a combination of several different things that just add up to a little bit too much, where one of those things might not be so bad and we can work with it, but then something else comes and something else comes, and soon, then this mother suddenly has like, okay, 3 strikes and you're out kind of a deal, or you know, not quite that simple, but that just makes it not.
On the other hand, as we hear from clients who are like, I've been told I'm too high risk because I've had a C-section already.
Mm-hmm.
But that's, you know, most women are good candidates for attempting a birth vaginally after they've had a cesarean, either 1 or 2 cesareans is what our state regulations say. So they've been told by a provider that they, you know, can't ever have a baby vaginally, and you know, with our care, and most of the time that's not proven true. They've successfully had a vaginal birth. So
I also think because we spend so much more time with women than the typical medical model does, that makes out of hospital birth with a midwife a safer option, because we know so much more about them as a person, as a family. And we may not just read what they've written on a piece of paper, but by doing the things like palpating their belly, asking them questions, finding out things, just because of the length of time that we have in a visit. When you have an entire 45 minutes or an hour to spend with a client, you talk a lot and find out a lot more than just focusing on the belly that Julie was talking about earlier. I also think that I know I would much rather say we probably could have stayed at home than I wish we would have gone in. I think that all of us are constantly evaluating our care during the course of pregnancy and labor as to focus on what is the safest option for mother and baby at the time.
Good information. And again, you know, knowing the woman as a whole and having in a professional capacity a history and a relationship with them, so that you can see all of these other aspects that are contributing factors in making their decisions, leading all the way up until labor and delivery. So Jennifer, out of left field, tell us about pelvic exams in labor and delivery. Do you have protocols? Do you have preferences? And what about the birthing people who have their other opinions?
So again, I think it goes back to a relationship that's been established all throughout pregnancy. You've gotten to know one another. You've had that opportunity to build a way to communicate effectively. You've learned about each other and built a rapport of trust. And as I arrive at labor, sometimes as a midwife, I can take in a situation of walking in by observing mom, observing her during a contraction, observing her contraction pattern, listening to the sounds that she may be making or the sounds that she's not making. And sometimes you just can assess based on the picture that is presenting to say, oh, you know what? I really think that we're going to have a baby real soon, and mom is doing her thing and it's working, and I just don't think it will be long. in that particular situation, it would be, I would ask the mom in between contractions, very softly and quietly, not to pull her too much out of her labor space. Do you want to be checked or not? If she says no, then we'll probably be holding a baby in an hour or two. And if we're not, then we may revisit that. Like, there's not this hard, steadfast rule of walk in the door, put my gloves on, and let's see where we're at, or let's see if I'm going to stay or if I'm going to go. It's really about protecting this space and taking in the picture that is presenting. Sometimes I might walk in and mom greets me at the door and she's chatty and talkative and, you know, puts her hands on her belly and says, oh, here comes another one, but she talks right through it. That might be a mom that I feel like needs a little more perspective about the progression of labor. So we might talk about what other signs and symptoms she's having. We might have a conversation about, you know, what's the scale or the spectrum of what the sensation is. And then I may offer to say, would it help you in this conversation of perspective to kind of know what your cervix is doing with this intensity of the pattern that you're experiencing? And it always seems to work out. Those mamas just always seem to have the right answer as to whether they need or want to be checked to their greatest benefit. And I follow their lead. It's very rare that I feel like I need to impose what I think we need to do, because offered the options and explaining progression and with good understanding, those mamas know. They know what they need or what they don't, or what would be helpful to them or what wouldn't. And I really think there's a lot of value in that.
Thank you for
Midwifery
that.
care is about informed consent with our clients. That was one of the biggest reasons why I had to get out of attending births in the hospital regularly as a doula, was watching things be done to women without their consent. That just got harder and harder for me to sit back on the sidelines and watch. Sorry to interrupt.
I think that's really important. Yeah. So it puts the birthing person, you know, again, like at the center of making these decisions. Hopefully, you know, obviously the baby always comes out. I don't know, right? Talk to us, Robin, about what happens after the baby comes out. What is a typical expectation for someone giving birth in a midwifery center or with a midwife?
I think we all instinctively, as baby's coming out, just have this movement of moving the baby over to mama's belly, and covering baby with a towel possibly, and just gradually, you know, just watchful waiting. What color is the baby? Is the baby changing colors correctly? Is the baby starting to cry? Is the baby spontaneously taking a breath? You know, we'll probably listen to the baby without being too obtrusive, without being too, you know, in the way, so to say. And so that first hour is pretty important to let mom and baby bond. And so we try to, we observe a lot. We don't say a whole lot, and let them just, we kind of take baby's cue and mom's cue, what they need from us.
It's
Awesome.
pretty standard, I think,
Yeah.
across the board is to, you know, one of the questions parents ask often is, what about delayed cord clamping? Well, you know, if we put the baby on your chest or your belly, we aren't doing much. We're just waiting and watching, and you're falling in love with your baby, not paying attention to us, you know, and so,
Clamping the cord's usually the furthest thing from our minds. Yeah.
Absolutely. And Jennifer, can you talk to us about the first 24 to 48 hours once the baby is delivered?
So by the time postpartum is drawing, that immediate postpartum on the day of the birth is drawing to an end, we go over what we call postpartum instructions. And I think all of us here have those. And we talk about what the next 24 to 48 hours for mom might look like and what the next 24 hours for baby might look like. We talk about what's normal and we talk about what might not be normal and when to reach out to us or when it would be more important to reach out for us. One of the very last things that I say to clients is I remind them that I am just as on call for them in this postpartum period as I was while I was anticipating their bodies going into labor. That sometimes, whether this is your first baby or your fifth baby, sometimes you're sleep deprived, sometimes you're anxious, or sometimes you're feeling a little off as far as what you feel confident in. If that's the case, I encourage those families to reach out. Let's reach out, talk about it. I'm trusting you to reach out if you need me, as opposed to me constantly hovering and saying, do you need me? Is everything okay? How's your bleeding today? What have you eaten today? I go over those things. I give examples to those things. We talk about those things. And then I tell them that I will trust them that if they are hesitant about anything regarding postpartum progression, that they reach out to me. And then I go back to visit them in that 24 to 48 hour period. I always do a home visit for that visit. And I tell them that I expect to find them still in bed, still in their pajamas. I might, see several baby outfits and maybe some dirty diapers that haven't even made it to the trash can yet. But that tells me that they're taking their healing time and their bonding time with a great responsibility. And that's meaningful to everybody in their family. And that's meaningful to me because that means that they're really involved and engaged in their postpartum healing period. From there, we assess whether there's a need or desire to do a 1 week visit or whether they feel confident and comfortable waiting until 2 weeks. And so that's when we make that decision. And then we make decisions together throughout that 6 week time period.
Thank you. So a few thoughts from Tracy, and then we're going to get another question from Jenna.
As far as postpartum care?
Yes, please.
I pretty much just would echo what Jennifer has already said. I do believe we spend a lot more time with clients postpartum than they get in the traditional medical model. We are able to, if a baby has a lip or tongue tie and mom is getting cracked, bleeding nipples, we're able to pick up on some of those issues a lot sooner than might happen if the client doesn't have midwifery care, and direct them to the appropriate person that can help with that, whether it's pediatric dentist, cranial sacral therapy, chiropractic care for mother or baby, either one.
And I think something important to note also is that you are the primary caregiver for the child as well as for the mother in an official capacity. And so it's one set of eyes who knows the whole story and circumstances that are following this birth journey, as opposed to someone.
I'm sorry to interrupt.
Go ahead.
We do encourage families to have a pediatrician picked out before the birth in case there's an issue that we see at the birth that we think needs additional follow-up, but we are able to provide care up until 6 weeks as providers for the mom and the baby as well.
Important, very important information. Jenna, how about you? Do you have a question for us?
Yeah, I was curious about during pregnancy ultrasounds, and whether, like, as home birth midwives primarily, that whether you have a recommended protocol in that or required protocol. I know some birthing people prefer not to have any ultrasounds at all, and I was just curious how y'all feel about that, knowing that you'll be at home versus like at a hospital.
Let's not all jump in at once. How about you, Julie?
If mom's unsure about her dates, then we can offer an early sonogram so that we have, like what Jennifer was speaking to earlier, that we have a well narrowed down date. So we have an estimated due date. We don't have some wide range. And then our particular protocols are to have at least one diagnostic sonogram in pregnancy, just to make sure that baby doesn't have any issues. for example, if a baby was diagnosed with a heart defect, then that would definitely not be beneficial for baby to be born outside of a hospital. And so things like that can be caught with this diagnostic ultrasound. And, you know, we don't recommend that they go in for the cutesy 3D, 4D, you know, family keepsake picture ultrasounds. It is a diagnostic tool. It should be used as such, but it is important. I mean, that could be life altering for a baby born in a place that they medically would need a higher level of care. It's our opinion that that's what we want of our clients, and they know that coming in. And so if it's not the right thing for them, that they choose no ultrasound, then another provider would be a better fit probably.
Good information. So I'm going to move on to the next question because we are starting to wrap up on time. Just going to put this out there. Raise your hand if insurance sucks. That's right. I said it. Okay. So how does it work? Is this something that Tracy, how about you for insurances? Like, one of the first questions I imagine you get.
It is a frequent question. I do not accept, I'm not in network with any insurance companies and do not subcontract with anyone to do insurance reimbursement for me. If a client has insurance, at the very least, usually their insurance will cover labs and ultrasounds, but many times they pay totally out of pocket for the rest of their care. I do try to take that into consideration with my fee schedule. If someone can't use insurance to help cover the costs of their out-of-hospital birth, I try to help them work out a plan that works for them.
Fantastic information. How about you, Ms. Heller?
I do it. Well, it's never about whether I accept insurance nearly as often as it's about does your insurance accept me?
Right.
And fortunately, I love what I do, and I have a lot of area of expertise when it comes to growing and birthing and caring for babies and families. And I leave the insurance billing to the experts that is their passion. So I do have an insurance biller that I work with. I would say that I probably get 10 to 15% of the families that work with me, their insurance does end up paying. And I bow down and give all of that kudos to the biller that handles all of that for my practice. So as families choose their provider, if they have chosen to work with me as their midwife, I connect them with my biller, and then she helps maximize and optimize their insurance, paying me or them, it depends on the policy, the maximum amount that they're willing to pay. So it works out probably 10 to 15% of the clients that come to me.
Thank you. How about Westover Hills?
It's a little different with the facility. Insurances are slightly more willing to pay, but still, for example, there are some like Blue Cross Blue Shield is physician owned, so they are not going to pay. They absolutely refuse to pay for out of hospital care. TRICARE refuses to pay for us since we are not certified nurse midwives. Other insurance companies like United Healthcare, Aetna, they're a little bit better. With the facility, with the birth center facilities, they're a little more, again, willing to give what's called a gap exception or a network exception, where they'll pay in-network rates. But they're few and far between, and clients have to beg and plead and appeal over and over and over again before they're accepted, which can wear people out. It can wear people out significantly. Some of them will pay a facility fee, but not for our midwifery services. It varies. Every individual policy from every individual company is so vastly different. We cannot say that the number one question we get asked is, what insurance do you take, or do you take insurance? And like Jennifer said so well, It has nothing to do with that. It's who's going to accept us.
Absolutely. And the policies are ever changing.
And a couple of
For
things to
sure.
consider is, first of all, deductibles are getting higher and higher.
Yeah.
And now that, if you're looking to become pregnant towards the end of the year, where you're going to have a pregnancy that spans 2 calendar years, you're going to have to meet your deductible for 2020 before your insurance comes in and takes effect. And then the birth is happening in 2021, you're going to have to re-meet your deductible.
Yeah.
And maybe for baby also before they kick in. So having a midwife as a provider, we don't do that. We have our fee, which is our fee for the pregnancy. It's
The whole
contracted. It's the whole package. And so you wouldn't have to meet your deductible. So definitely midwifery care is probably going to be less expensive than meeting your deductible twice. And then a very underutilized benefit for people now that it's starting to come up on enrollment season here shortly is health savings accounts and flexible spending accounts. Those are very underutilized and can pay for midwifery services, and it just kind of takes some planning. So if you're planning on becoming pregnant, then make sure you're putting that aside in your HSA or FSA account beforehand, and that at least you would save whatever your tax rate is. You're not paying taxes on that money, so you would save your tax rate on your money to use for the birth.
So outside of insurances typically being a barrier more so than a benefit to accessing midwifery care, do you have any other thoughts on what Jane Q. Public can do in order to navigate being able to have access, or if there are public policies that you see specifically that should change in order to make midwifery care accessible to more people, specifically underprivileged demographics?
Well, Medicaid is not very willing to cover our expense or our services either, and that's a huge barrier because the certain populations are, that's what they have, that's what they expect and to pay for their care. And we get a lot of calls from people who have Medicaid wanting to know if Medicaid will pay, and we have to. It hurts to have to tell them no, it doesn't. Medicaid will still cover for the third-party services such as labs and sonograms and things, but getting Medicaid to pay us, especially for home births, is almost non-existent.
And if you do have your, manage to find somebody to bill for that, and you're successful in getting reimbursement from Medicaid, the number of clients that you would have to maintain your practice would be up there with the OB-GYNs, and then we wouldn't have the time. And so
it's not a midwifery model any longer.
The reimbursement is so low that it's not sustainable for a small practice.
Right. Definitely understandable. Tracy, Jennifer, any other thoughts on that before we move to close?
I do still encourage clients to contact their insurance companies, because insurance companies need to know this is a need that's not being met, and also to find out how much money they could save if they would cover midwifery care.
Fantastic information. You're right. Overall, it's actually so much cheaper to deliver a baby the normal way. How about it, Jennifer?
And again, exactly what Tracy said. Even if I do have families that end up paying out of pocket, I still encourage them to take their itemized receipt with all of their diagnostic codes and all of their insurance codes on it and submit it to their insurance companies, requesting reimbursement to them. And if nothing else, I'm hoping that these insurance companies are just deluged with requests, and that at some point all of those requests go in a file, and then at some point somebody picks up that file and says, wow, did you know that in our insurance group that we have hundreds of families paying out of pocket a fraction of what a hospital birth costs?
Right.
It's Sometimes it is about just landing on the right desk. In addition to that, I do offer people that qualify for Medicaid a discount, and I also often end up also allowing a very long-term payment plan. And I have found that the families that really want it will say, I don't know if you can do this, but this is what I can do. And 9.5 times out of 10, I agree to it because that's where my heart is. My heart is to serve families and meet them in their time of need, however I can. So part of that includes payment plans that last a year, or unfortunately it's not very many, but it is one of those things that if I feel like they're showing up and saying, so I can't do what you would normally ask, but I can do this, then I try to meet them wherever they're at.
Thank you so much for that answer. It's important because again, like we are talking about a professional, but also in some ways a personal relationship at a very critical point in a person's life. And so just feeling cared for, even in a financial way, or considered, you know, their position is I feel so important in facilitating a caring relationship with a care provider. So last words, if you have a motto or a principle or a favorite quote, something that just succinctly brings together. I know, right? It's so poetic. A little bit cheesy there, Robin, I realize, but tell us a little bit about, you know, what makes Westover Hills, who you are, and how should we contact you?
Let you do that.
Leave that to me. She said Robin.
We can't tell you what our personal mottos are because it wouldn't be really
Not
good.
for mixed company.
There's a midwife for every person, and so when you meet and talk to the midwife, you're gonna know if y'all are gonna jive or not. And if you don't find that midwife that you perfectly mesh with, then keep going, because you'll find the right one for you. And you don't necessarily want the one who's just gonna say yes, 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 and do everything, you know, be your yes gal. You want somebody who's gonna be able to tell you, well, that, you know, these are things to consider that may not be in your best interest. So you may need that in your care. And we're on Facebook. You can schedule your own appointment through Facebook or through our website, westoverhillsbirthcenter.com, or you can call the office. I answer the phone Monday through Friday, 10 to 5. Usually 24/7, but you know, that's our business hours, is 10 to 5. Our phone number is 210-725-0428.
Thank you so much. How about it, Tracy?
You can find me on our website. It's tracythemidwife.com. If you type that in, I'll come up. Luckily, the San Antonio area has a lot of midwives, and as Robin and Julie have already said, there is a midwife for everyone, and I encourage clients to interview more than one midwife. We're very blessed here because we have a lot of midwives. Some towns or cities or areas have midwives drive multiple hours to provide their care, and we have a lot of options in San Antonio, and I'm very grateful for that.
Fantastic. Thank you. Jennifer, tell us about what drives you and how do we contact you?
I feel like the pregnancy journey is the beginning of all things parenting. You know, it starts with growing a baby and learning what that responsibility looks like, and taking ownership of that process, and learning how to explore options and resources, and how to find your voice in the sense of what kind of parent do you want to be, and having somebody help you navigate those tricky waters is so often gives you a really solid foundation and a really nice beginning for that lifelong journey, that part of your lifelong journey. I do have a website. It is www.birthexperiencemidwives.com, and I am easily accessed on social media as well. And there is also a wonderful collection of all the midwife opportunities in the San Antonio and surrounding areas through the San Antonio's Midwives website. And so that the nice thing about just going to that website is that you see the vast majority of all of us there, and links to all of our contacts and websites, and it's a great place to start.
Thank you so much, Jennifer, for that information. And thank you to all of you again for joining me for this evening. I hope that it will be informative, especially going forward for people who are looking for, I guess, the beginning information of what to look for in a care provider. And in addition to the website that Jennifer Caheller mentioned, you can also find all of these midwives and other birth professionals to build your birth team at the sanantoniobirthnetwork.com. Feel free to peruse the directory. And if you have any other questions for the midwives on our panel or for myself or any of the other professionals, feel free to contact us there, sanantoniobirthnetwork.com. Ladies, thank you so much again for joining me this evening. I really hope that you enjoyed our conversation. I know that I did for sure. And hope to see you again on the birth side. So thank you, everybody.
Thank you.
All right.